As the world celebrates the dawn of a new year, 2020, the World Health Organization, WHO country office in China, is informed of a cluster of cases of a pneumonia of unknown cause in Wuhan, Hubei province. The symptoms include shortness of breath and fever. A novel coronavirus was eventually identified. On 30 January 2020, following the recommendations of the Emergency Committee, the WHO Director General declared the novel coronavirus outbreak a public health emergency of international concern. Zimbabwe reported its first COVID-19 case on 21 March 2020. As of 31 October 2022, the country had experienced 4 main COVID-19 pandemic waves and had recorded a total of 258,169 cumulative number of cases, including 5,610 deaths. In responding to the COVID-19 pandemic, the government of Zimbabwe, in partnership with all sectors, stakeholders, and civil society, showed the highest level of commitment and laid a foundation that enabled a government and society response, distinguishing Zimbabwe as a leader and fast mover in the region. The response to the COVID-19 pandemic was coordinated through a national task force from the Office of the President and Cabinet. Through a multi-sectoral approach, the government of Zimbabwe led an effective, well-coordinated, and robust response to the COVID-19 pandemic. While many constraints and challenges were encountered along the way, ultimately, many lives were saved. Crisis response strengthened, valuable lessons were learned, and under the government of Zimbabwe's steady leadership, the nation has emerged today better prepared to handle the next emergency. 2 years later, this is the story of how a nation came together to fight and overcome COVID-19, one of the biggest health crises history has ever seen. The government of Zimbabwe declared the COVID-19 pandemic a national disaster on 17 March 2020.
Let us continue to social distance, to wash our hands with soap under running water, and to sanitize our hands with alcohol-based sanitizers. We must all feel the urge and the responsibility to protect ourselves, our families, our neighbors, and thus our nation.
March 2020 was really a frightening time. Although by the time that WHO declared the COVID-19 pandemic, many countries, including Zimbabwe, were already at full throttle in terms of preparing for the pandemic. I recall that the pandemic was declared on the 11th of March 2020. Zimbabwe had actually started preparing to respond to this pandemic from end January 2020.
The country went on to launch its National Preparedness and Response Strategic Plan on 19 March 2020, 2 days before it recorded its very first case on 21 March 2020. Within 10 days, on 30 March 2020, the government introduced a national lockdown in order to prevent importation of cases, while continuing to urgently prepare to implement the National Preparedness and Response Strategic Plan. A survey led by a team of global scientists in August 2020 revealed that Zimbabwe was able to delay the spread of COVID-19 through stringent public health and social measures that were enacted early on, including the strict lockdown in March 2020.
Just before the pandemic hit us, when I was Permanent Secretary in the Ministry of Health and Child Care, we had set our target as universal health coverage, and we were working very hard to strengthen our health systems so that we're able to reach that target. And in that strengthening of the health systems, we specifically focused on building the systems that would enable us to manage epidemics, outbreaks, pandemics, and so on. So we're working very well towards that. So when the pandemic hit us, we said, wow, we're already on the right path. We're not changing our priorities. We're going to continue strengthening those health systems. But we're now just going to not only focus on the outbreak and pandemic strengthening in terms of response, we're going to now also ensure that our specific planning for COVID-19 and, of course, resource mobilization was very much stepped up. And in order for that to work, one requires credibility. In order for that to work, one requires to act and not just talk. In order for that to work, one has got to be consistent and constant. And we address all those issues very carefully. In terms of credibility, we made sure that whatever we were doing on the ground was based on science. We're looking at the WHO guidelines, for example. We're looking at our own local data that we collected, analyzing it and turning it into the science that we wanted, and provided science or evidence-based response, which became very credible to our stakeholders and the communities that we were serving. We also really saying we've got to act here. We can't just talk and cry about it. And this is where we mobilize all the partners to work with us on the ground. Those collaborations came in handy, and we're able to produce the results that confirmed that there was action.
In May 2020, the government of Zimbabwe operationalized the 24-hour COVID-19 Command Center. This was in line with the Civil Protection Act following the government's declaration of the pandemic as a national disaster. The Command Center came to be a critical part of the government of Zimbabwe's COVID-19 response, a central location where information was collected, processed, and evaluated in real time, supporting the coordination and decision-making efforts related to the quickly moving pandemic.
The response plan developed by the government of Zimbabwe became our blueprint, but now mainly following the guidelines given by the World Health Organization. The government of Zimbabwe created an ad hoc interministerial task force on the COVID-19 pandemic, which was further then divided into 8 subcommittees. But later on the 27th of March, Cabinet made a decision that there must be a command center which was to do the legwork for all the 8 subcommittees. The creation of the COVID-19 Command Center was a result of realizing that there were certain things which were not necessarily of a health nature. You could not then afford to deploy your health practitioners in doing certain logistics. So the command center was then created in May, on the 25th of May 2020, and we made sure it was then equipped and staffed with the right people.
Despite the stringent public health and social measures that the country enacted very early, the number of new cases accelerated in late June 2020. Newly reported COVID-19 cases increased by 8.9% on average each week between 23 July and 19 August 2020. As new reported cases surged in July 2020, the government introduced a curfew on 22 July 2020 and required citizens to stay at home unless making essential trips. During this time, frontline workers and other essential service providers such as police, health workers, government officials, and others continued to report to work to provide essential services.
So pakatanga COVID-19 ndaichika kuti ichapera rini, how long we will be kept indoors, tisingakwanise kubuda, tisingakwanise kuinteract with other young people. So I was so scared, I was worried, I was hopeless, and you know, COVID-19 took a lot of our social time. We could not socialize as young people.
Although borders were closed, Zimbabwean citizens and returning residents were allowed to return home from the diaspora and neighboring countries. Transmission among returning citizens was therefore a major concern during the pandemic.
When the pandemic started sometime in 2020, our role as port health officers was to screen everyone who's getting into Zimbabwe. Here in Beitbridge, initially we were at the entrance just before immigration, making sure anyone who enters Zimbabwe, before stamping the passport, we check the temperature, we check the general wellness of the person. Where we are suspicious, we are referring to hospital. And when it started, people were so sketchy. They were not complying to our screening routine. They were not used to it. It was something new. So people were trying by all means to avoid us. So we had to seek reinforcement from police and later army, so that people will be controlled and will comply to the new regulation of screening. And with time, people got used, and when the first case was recorded in Zimbabwe, almost everyone now was willing to be screened.
Yeah, actually the most important thing was to line the objectives of the program. That was to guide against infection diseases coming into the country. So basically we're supposed to be strategically based here so that we guide that at the end of the day there is no entry of diseases into the country. However, as we know that people move in different ways, in different styles, at the end of the day the disease was in the country. So the most important thing, or our key role then, was to guide and minimize those cases which are already there and make sure that there is no transmission of the coronavirus to either within the country or outside the country. Because personally we believe that when it comes to issues of pandemic, if one country is affected, automatically the other country is affected. So we're doing a double job in guiding against all diseases, or all people are coming to the country, so that we screen and we find that they are not having signs and symptoms. Where possible, we're also doing some testing where people have not been tested. And then at the same time, we're also looking at people who are going outside the country to make sure that they go whilst they are free of the infection.
Remember, this pandemic did not only affect Zimbabwe, it was transboundary in nature. A lot of people were now coming back from our neighboring countries, especially South Africa and Botswana, were to make sure that their transportation was put in place. And at the height of COVID-19, every 30 minutes, either there was a bus leaving Plumtree or leaving Beitbridge. Whenever there was congestion at Beitbridge, we would work out some mechanisms of decongesting those centers. Otherwise, they were going to be COVID-19 super spreaders. Remember, and we had also to make sure that the testing kits were always available at the ports of entry. And you know, there were some people who went to South Africa without proper documentation. They would use undesignated entry points. Then the uniformed forces in our Civil Protection Committee, we have what we call Search, Rescue and Recovery subcommittee. We had to apply the principles of that committee to ensure that we manage to, where possible, to fish out those who use the undesignated entry points. And we want to thank the public because they really cooperated to say, we have a gentleman here, I don't think he ever used the Beitbridge or Plumtree. He must have used an undesignated point. Then the army, who are part of the the army, the police, and other security forces were then deployed to bring back those people to the quarantine centers.
Misinformation and fake news was a serious challenge throughout the pandemic, with many citizens holding misconceptions about how the COVID-19 virus was transmitted. A survey led by a team of global scientists in August 2020 indicated that only 25% of Zimbabweans believed that they were at personal risk of being infected by COVID-19. Based on this low-risk perception, it became apparent that risk communication and community engagement strategies be a critical pillar in dispelling misinformation and improving citizenry understanding, not only of COVID-19, but of how, as the public, play an important role in managing public health emergencies.
The biggest challenge was social media. Not that social media is not something which we don't embrace. We do embrace social media, but the challenges were coming from disinformation and misinformation. There were so many things coming up, not just coming from locally, but internationally. There was so much on social media, and that would confuse people. But as a ministry, our job was to make sure that we take all the information which is coming from World Health Organization, from our government, and all the precautionary and preventative measures which were put into place. We would then put that to the masses, to the communities, through all channels. We used all channels: social media, traditional media, our newspapers. We also made sure that we use the provincial newspapers, and we also made sure that we get to each and everyone without leaving anybody behind or no place behind. So where there are no newspapers, where there are no radios, we had to make sure that we use the traditional ways of communicating. That is using the religious leaders, the traditional leaders, to make sure, as custodians of the people, the information trickles down to each and every Zimbabwean.
I remember at ZBC, we even started a daily program where we would speak to the then Permanent Secretary and the Ministry of Health and Child Care, Dr. Agnes Mahomba, on what was happening. Every day in the morning at 6:30, we'd give them a program. We'll be discussing the numbers, the figures, the new cases, the deaths, the recoveries, what was happening. We even, I remember when she moved to be the Chief Coordinator of COVID-19 in the OPC, we actually had a team of experts that would call in every day. Like for those underlying conditions on the social side, on the social welfare side, would have experts coming in every day. Now there were questions on the streets, and those experts were coming in to address those questions so that people have the right information at all times. So we're using facts, we're using information to counter the misinformation and the lies that were flooding the streets.
According to a May 2021 United Nations Children's Emergency Fund (UNICEF) report on education, COVID-19 affected the learning of millions of children around the world, including 4.6 million children in Zimbabwe. What the pandemic clearly revealed was the need for innovative educational access and continuity of learning in emergencies. While loss of learning mostly occurred due to school closures, the government of Zimbabwe, with support from partners such as UNICEF, introduced innovative learning platforms and methods such as the Learning Passport and radio lessons. In May 2022, the Zimbabwe Vulnerability Assessment, ZIMVAC, indicated that about 84% of children of school-going age were back in school.
Schools must prepare to open and put in place measures which observe the World Health Organization protocols and the national COVID-19 guidelines. Virtual learning or long-distance learning is encouraged where possible. Universities and colleges must also prepare to open and ensure compliance with the World Health Organization protocols and the national COVID-19 guidelines. Virtual learning or long-distance learning is equally encouraged where possible.
Zimbabwe is a very interesting country in the sense that when we have a COVID-19 pandemic, like every part of the world, we close schools because we're trying to figure out what to happen. But I think we should give credit to the Ministry of Health and also the Ministry of Education for a unique partnership that is rare to find anywhere in the world. Number one, the Ministry of Education and Health put together a response plan for the COVID response in school. The Ministry of Health established what we call a rapid response team that goes to school in case there is a COVID outbreak and respond with it. The Ministry of Education opened their door to allow that kind of engagement and interaction to care for kids and parents in school because the Ministry of Education was particular about continuity of learning. But they didn't stop there. The Ministry of Education introduced a lot of innovation into how children can continue to learn even with all the disruptions from COVID. They introduced TV lessons, radio lessons, digital lessons. They train teachers to live with these new areas of work. Lastly to say, the Ministry of Education in Zimbabwe has a learner welfare department that took charge of ensuring that children are not only in school, but that the school is safe for learning. Again, another massive result we achieved there because schools opened, our children were back in school, we managed COVID, and learning has continued. Again, on behalf of children, we are very happy as UNICEF.
Beyond the classroom, youth in their communities felt the social impacts of the COVID-19 pandemic.
Because people were locked down in their homes, we were able to reach them through their mobile phones, through calls, texts, and social media as well, including WhatsApp. We were supporting on average about 14,000 adolescents and young people per week, whereby they were put in WhatsApp groups and we're educating them through what we call a youth advocacy leadership program. And during that time, a lot of young people were actually going digital, and that was a huge opportunity for us.
The lockdowns disrupted most economic and life routine activities for Zimbabweans, including the simple act of attending weekly worship services. Despite this disruption, the church played the critical role of providing leadership in communities and in supporting government efforts in risk communication and vaccination drives.
The basic thing that we know how to do is to pray. That's the number one thing. So we called people for prayer. Various prayer platforms were created. Now we were learning to do things online. To start with, it was WhatsApp groups, people praying, people asking questions. You remember that people now started thinking this is the end of the world. Number two, this was, if it was the end of the world, people now when vaccines were beginning to be produced in that very quick manner, some said 666 is the end of the world, it's the mark of the beast. And with the quest to provide solid leadership, informed leadership, the church, one of the things that we did was we set up a group of professionals to study the phenomenon, to study the issue of COVID itself, to study the issue of the vaccines that were now being produced vis-a-vis the misinformation that was going on. So that's one of the best things that we did. We put together all our professionals, epidemiologists, scientists in different various places that we had in the church to say, provide us information on what is going on based on people we trust, people we know believe in God and fear God, because some of the misinformation was this is a gimmick for people who are trying to make money out of people, or people who are trying to reduce numbers on earth. So we needed to do that. So we provided leadership in bringing together specialists to look at this issue so as to give correct and accurate information.
As a church, during that time when we realized that this was a very serious pandemic affecting our people, we started organizing workshops for the people to have a better understanding of what COVID is all about. And the best measure that they can use to actually protect themselves. And we also created different committees that could help us to fight the pandemic. And part of those communities, we used the local human resources that we had in our churches, especially the doctors, the nurses, and all those who were in the Ministry of Health sector, to help educate our people understand what COVID is all about.
Pakutanga zvairema tichidzidzisa nekuda kwekuti vamwe vakurira muchipostori havakurudzirwi havafaniri kuenda kuchipatara ende zvavakazvijaira, saka zvairema. Asi nekuda kwekutaura nevanhu tichizama kuchengetedza masecrets pachipostori, umwe aigona kutongoya achiti vari papi, then toenda tichinobatsira pakuti abaiwe, nekukurudzirawo kugeza maoko. Vamwe chaivo vaitokurudzira, vaitoramba kuti mishonga hatide, asi nekuramba tichidzidzisa pamarufu nepane pakaunganwa tichikurudzira zvese izvozvo, tichivapawo maideas anovaka, vazhinji vakasvika pakugutsikana nazvo.
Governments around the world were in the race of a lifetime, a race to flatten the COVID-19 pandemic curve, change people's behavior, increase testing for the virus, and most critically, to develop and deploy a vaccine. The clock was ticking.
A lot of action was done quickly at the beginning of this response. It was so fantastic that at that very start, the highest level realized that it was so important to be very committed to this response, otherwise it was not going to work. The whole of government and society approach was going to be difficult if we didn't have that commitment. So we actually got that very strongest commitment from the very highest level from the start.
We had to put the whole society to be part of mechanisms we are going to put in place to fight this pandemic. So, His Excellency the President called for a meeting of all who could come from business, civil society, but the Ministry of Health and Child Care remained at the core of making sure that everybody survives.
Worldwide, the COVID-19 pandemic spread rapidly, leaving even the most well-equipped health systems vulnerable. Government therefore set out to strengthen the nation's health system in order to effectively implement the National Preparedness and Response Strategic Plan, a plan that was guided by the World Health Organization's recommended pandemic response pillars, including disease surveillance, laboratory services, case management, provision of essential health services, infection prevention and control, risk communication and community engagement, points of entry management, vaccines deployment, procurement, and other logistics and coordination. Some of the specific interventions implemented included the upgrading and expansion of healthcare facilities, the expansion of PCR, polymerase chain reaction testing, from one central lab in Harare to all 52 district labs, and the introduction of local genomic sequencing, a significant development that enabled scientists to identify new COVID-19 variants in a timely fashion. In addition, a COVID-19 risk allowance was introduced on 1 March 2020 for all healthcare workers. As the pandemic unfolded, governments around the world grappled with how best to finance this public health emergency in order to mitigate the pandemic's negative impacts on people's lives and livelihoods. Over and above planning the National Preparedness and Response Strategy, Zimbabwe made significant strides in mobilizing both domestic and partner funding for its implementation. This resource mobilization was a key result of the multi-sectoral approach undertaken for implementation of the national strategy. The government, however, prioritized mobilization of domestic funding An estimated $305 million United States dollars of domestic funding was mobilized, translating to 84% of the national response budget by the end of 2021.
It's clear that the government of Zimbabwe did most of the heavy lifting in terms of funding the requirements for the pandemic response. 84% of the resources came from government, which is $305 million US dollars, and only 15% came from our partners. We thank the partners as well, but it's clear that government had to be ready financially for this to be successful as an intervention. The resources were actually public resources in the main from the fiscus, from taxpayers, and we thank the taxpayers for having provided these resources. So we had, as I said, that the rollover surplus from the previous year of about 100 million, and then we drew down on about almost 50 million from our SDRs the following year, again towards vaccine acquisition. But prior to that, we had to divert some resources towards this pandemic from other areas within the budget. In 2019, for example, you will find that the infrastructure program hadn't quite taken off to the same extent as it has had now. So we had some room to kind of shift resources from infrastructure development towards the pandemic response effort. And then only in 2021 did the infrastructure program really accelerate. By that time, we had covered quite a bit of the demands from the pandemic. So we had to shift budget around like everybody else. And we, of course, as I said, 16% of the resources came from partners, and we thank them for that. They responded. We asked for their help here and there. But we also thank the corporates, private corporates that donated PPE, sanitizers, and so forth. All of these resources are welcome, and they did go a long way in dealing with our response effort.
Along with mobilizing the necessary resources to respond to the pandemic and save the economy, the government of Zimbabwe was engaging in a parallel effort to protect people's livelihoods. Among others, 2 measures undertaken by the government of Zimbabwe to support vulnerable groups during the pandemic were distribution of food aid, as well as cash transfers.
Zimbabwe runs a robust social protection program, which starts with productive social protection and around the Fumvudza or Intwasa program, where we give people, many in the villages, 2 million households easily, seed, fertilizer, and extension services support. And then we support, those who are vulnerable who cannot afford school fees through the BEAM program for schooling, the elderly, and the disabled, and so forth. So we have a robust social protection program. So support for that is critical. But also on the food front, we have a food mitigation program where every year we set aside about 500,000 metric tons of food, which is held at the GMB, strategic reserves, and we draw down from that. Right now we're drawing down at an average rate of about 25,000 metric tons of grain a month to support the vulnerable in terms of their food between 1st of October up to end of March. Then we assess, because then the harvest, next season harvest should be due then, but we have enough food going forward. So food security is critical for economic recovery.
When the lockdown was imposed, we wanted to uphold the commitment made by His Excellency the President that no one was going to die of hunger. We stepped up the food deficit mitigation program across the entire country to ensure that we distributed grain to vulnerable communities. In fact, we increased the number of beneficiaries from the normal registers that we were using, because many people, particularly those that were in the informal sector, lost their livelihoods, so sources of income vanished overnight, and they then looked up to government for support, and we stepped up our grain distribution program. Secondly, we were distributing cash transfers in 23 districts of the country, and we made sure that on a monthly basis these cash transfers will be done. We also engaged our development partners, in particular the World Food Programme
and UNICEF. UNICEF is predominantly there for the protection of children, and they introduced emergency cash transfer programs in 4 districts of the country: Epworth, Highfield, and I remember the other one was Gutu. This was a new program, and the targeting criteria was to target households in the areas or districts that I've already shared with you, with cash transfers around $20 to $25 per person per household. So a household would ultimately, if it was a household of 5, they would on average get around $50 to $60 on a monthly basis. And again, this was targeted as a mitigation program to the COVID-19 pandemic.
In building the necessary capacities for rapid response to the pandemic, Zimbabwe rose to the occasion. In line with the government strategy and push towards self-sufficiency and import substitution, local universities and small to medium-scale enterprises set up units to produce personal protective equipment and hand sanitizers. Local pharmaceutical companies set up production of some medicines required to manage COVID-19 cases, and an oxygen plant was established in Manicaland, providing medical oxygen to strengthen patient management across the nation.
We had everyone who had something to doing what they could. Companies came up with quite a lot of equipment which was being used in our theaters. And so everybody, even the old women, were sewing masks in their own,
The stark reality of this was that all of a sudden those countries which produced or which used to export face masks, sanitizers, stopped. And then we had to do something, and we thank the government for its foresight and support also. They then said we need to capacitate our universities to start producing. So they gave us seed funds to start the sanitizer production. At the same time, His Excellency, the President E.D. Mnangagwa, donated 300,000 liters of ethanol to kickstart the process. And that was the beginning of everything. And then the PPEs. The good thing is that we already had a unit in the Faculty of Education which was producing academic regalia. So we had a few machines there, and they were already doing that. So we also said, design a mask, something similar to the surgical mask, which we can then share with our Minister of Higher and Tertiary Education, Innovation, Science and Technology Development. The first mask was, it met all the WHO guidelines, and our sanitizer was SARS certified, meaning the product was just the right one. 70% alcohol content, ethanol content, if I may say.
Across Zimbabwe, frontline workers and early responders, our doctors, nurses, and other health professionals worked tirelessly to respond to the pandemic, putting aside their questions and fears to face the challenges of the pandemic head-on.
South Africa unfortunately started recording a very high number of cases as compared to what we were getting here, and most of the Zimbabwean immigrants who are staying in South Africa started returning home in their numbers. So it was a nightmare for us at the port of entry at our local border between Zimbabwe and South Africa, Beitbridge border post. So we had to team up with the port health officers. We also had to pre-position our clinicians, the nurses and doctors, to assist in screening. So it was symptomatic screening, temperature screening, as well as testing. Remember, we also required people who were traveling to be in possession of tests. But unfortunately, for someone who was returning to their own country, most of these people, they did not even have the test done. So as part of screening, we had to test those people, all of them that were passing through the border. And it was very hectic, I must say, because at times we would test more than maybe 700 people per day, in excess of 700 people per day. It was tough on the staff, most of whom had to do very, very long shifts. It was quite a difficult time for us, but somehow we managed to pull through. We had our Minister of Health actually seconding staff from other areas to come and assist. I remember we had even people from the Zimbabwe National Army, from police, from the prisons and correctional services, actually coming to assist the local Ministry of Health workers in dealing with these huge numbers of people.
Disease surveillance, including testing, was an important tool used to fight the COVID-19 pandemic. In Zimbabwe and around the world, ensuring early testing for the rapid detection, isolation, and management of COVID-19 cases became critical to managing an unpredictable pandemic.
Before the pandemic, most of the funding for disease diagnosis was verticalized. To say if it's funding for malaria, it comes strictly for malaria, HIV, TB, you name it. But with SARS-CoV-2, we had to change our mindset. And I remember very well the first primers, which is a set of the genetic codes that we use for testing. We got them from China, but they just came as primers, no other accompanying reagents. And as a lab, we had to sit down, use the same method we use for HIV, take the other reagents from the HIV reagent set, and started doing the extraction and detection. So that capacity we had with HIV, we converted it to a SARS-CoV-2 detection. And also you look at the beginning, we only had centralized laboratories doing the tests. So it involved transporting the samples from different parts of the country. And that on its own, again, we had to rely on the TB sample transportation systems. We had to rely on the other hubs, referral systems, to get the samples to the country. We had also developed the capacity long back for sample transportation for biohazardous materials like the time of Ebola, when we were anticipating Ebola in the country. So we also used that same IATA training for high-risk pathogens, which is triple packaging. So that on its own, it involved integration of these different diseases to curb COVID.
As a private laboratory, as a public health measure, a positive for pathology was that for the first time, all the small towns around Zimbabwe were capacitated. Because initially, all the testing was in one lab, in Harare, at Harare Hospital. Soon, private players came to support the government, and we had several labs in Harare. People in Bulawayo, in Mutare, in Gweru still had to send their samples to Harare initially. So within a short time, machines were rolled out both in the private and in the public sector. So where there were little small labs in Chinoi, in Kwekwe, whatever, because of COVID, every little lab had to now have PCR capacity.
Globally, pandemic response measures such as lockdowns resulted in limited mobility and consequently disrupted a number of essential health services. In Zimbabwe, a December 2020 rapid assessment on the indirect impact of COVID-19 on essential healthcare services commissioned by the National COVID-19 Experts Advisory Committee confirmed that essential healthcare services such as malaria, tuberculosis, and HIV services were partially or completely disrupted during the pandemic, task shifting of selected essential health services to trained village health workers became more important than ever.
Taidanidzirwa murwere kana kuchinzi pona murwere anokurwara kupi kuti ndibve kumba baba vanga vasingatobvumi zvakanaka vachingoti uri kunzwa vanhu vari kufa munhu akabuya achibva kumhiri hatauri aite chii iwe unongoenda so uchati hunzira marwere pano kumusha tichafa nevana tichitarisira vanhu vamwe vane nhumbu handiti vanhu vane nhumbu vanofanira kuzogarira kuno kuchipatara so vaitoti kana tikagarira kuchipatara uko anati mati tisagara takawanda so tikaenda kuchipatara uko tichazopomedzana nevamwe takawanda so vanhu vatachivabatsira tichiti hai handei kuchipatara tinokutarisai ipo tichiti takawedzera dzimwe dzimba pane dzimwe dzimba dzisingagari takauya apa pamanesi pane dzimwe dzimba dzisiri maternity ward so takacreata dzimwe dzimba kuti hai munogara so mukagara so tichiva tikabva tikaisa futi pamusangano kana kuwhatsapp group kuti hai musahle kuti mukaenda uko zvichadai
tikataichiti mavillage health worker ese kana kuri kuti inguva dzekuti chibagwe vanhu vakuwana chikafu saka tofanirwa kuti mavillage health worker tese tivepo kuti tibetserane nokuti zvaisava nyore so asisu hatina kumboneta kuzviramba tichingokurukura nevanhu sezvo kuri basa redu semavillage health worker.
On 1 October 2020, international flights resumed from Zimbabwe. However, in December 2020, the government had to implement a nationwide lockdown after cases began to increase following the holiday season. Within 12 months of the COVID-19 pandemic declaration, several global research teams rose to the challenge and developed COVID-19 vaccines. In February 2021, the Medicines Control Authority of Zimbabwe issued an emergency use authorization, EUA, for Sinopharm and Sinovac COVID-19 vaccines, ahead of many countries in the region. Deployment of these vaccines immediately started with the Honorable Vice President, Dr. Constantino Gouveia Chiwenga, being the first to receive a jab at Harare's Wilkins Infectious Diseases Hospital. Although 2 other types of vaccines were later granted emergency use authorization before the end of the year, Sinopharm and Sinovac vaccines remained the mainstay of the country's vaccination program.
We started the COVID vaccination on the 22nd of February 2021. By that time, I think we had only a few centers which was vaccinating, and it was the first phase which was targeting the healthcare workers and other civil servants. So it was very busy that time because there were limited teams which were vaccinating, and like we have a facility, a Wilkins. That one was a very, very busy it's a hospital actually, but we're having lots and lots of people coming for vaccinations, and even some were coming even outside Harare from other provinces. And so when we saw that there were a lot of people coming to Wilkins, we could not cope with the teams. I think at one time we had about 7 teams. We couldn't cope. So we started to go to workplaces to vaccinate in workplaces like the government departments. There were some parastatals and some companies. So we were going there to decongest our facility, our Wilkins. And we were also making sure that our vaccines are available because the demand was just too much. It was very high.
In 2019, we had some resources after the year, a surplus of about $100 million US. So we're able to deploy this to acquire the vaccine early. We chose to go for the Chinese vaccines, Sinopharm and Sinovac. The reason being that these were our preferred vaccines, and they're traditional vaccines because they come from attenuated viruses. So they're similar to other vaccines that we're used to. So we went for those, and we're very successful in procuring them, and we got some donation as well. So we're very systematic in our vaccination procurement program, and even helped other countries, transport some vaccines. We even made donations to other countries in the neighborhood. So this was a very successful vaccine acquisition program as part of the whole overall response to the pandemic.
The February 2021 deployment of a vaccine in Zimbabwe marked a major victory in the battle against COVID-19. But the war was far from over. At the peak of its second COVID-19 wave in January 2021, Zimbabwe averaged more than 900 new cases and 40 new deaths reported per day, almost 5 times more than at the peak of its first wave in August 2020. Several months later, Zimbabwe would experience its third and worst wave, which peaked on 15 July 2021 with more than 2,300 daily cases, more than double the previous peak in January 2021. The surge in cases was likely associated with the Delta variant, first reported in the country on 29 April 2021. It was also associated with low vaccination coverage, as the vaccine deployment was then in its early months with few people having been vaccinated. Massive campaigns to push the vaccination coverage up were therefore immediately instituted across the country.
I wear 2 hats in that I am a pathologist who is laboratory based, but I'm also a pathologist who is mortuary based. So I wore 2 hats on that committee. I was informing the committee of what was happening on the ground in terms of people dropping dead. So every morning we go and we do postmortems. So each time a wave was beginning to develop, we would quickly see it because, normally we have 3 or 4 people from Glenview dying overnight. Normally we have 2 or 3 people from Mabuku. Last night we had 8 people from Glenview. Last night we had 16 people from Borrowdale. So we would be the first to raise the alarm bells.
There was a lot of misinformation, especially on social media, where people were saying the Chinese vaccine is meant to wipe out the African population and so forth. So there was a lot of vaccine hesitancy or vaccine objection within our local people. But eventually, as we had our RCCE team, that's the Risk Communication and Community Engagement team, which was moving around the district educating people on COVID-19, what it is, how vaccines work and so forth. So slowly we started to have people actually coming up and taking up the vaccine. And once we started the vaccination, it also meant that we had to open a completely new department which was dedicated solely to vaccination. And it included a static site as well as outreach teams where we would move around the district, both in urban and rural areas, trying to mobilize and vaccinate people.
The COVID-19 pandemic was a worldwide trial that changed our lives forever. Billions of people were in lockdown, unable to work, go to school, meet their friends, or connect with loved ones. Many died at home or in hospitals, separated from their loved ones in their hours of need. The pandemic forced us all to confront the true uncertainty of human existence and the fragility of human life.
When COVID came, it did not select. I lost, or we lost, from a church perspective. ICT represents the apex body of the church. We lost some of the best pastors. We lost ministers in this country, good ministers. We lost good civil servants. We lost good church people. We lost mothers. We lost heads of families. The lesson was, we need each other.
We lost colleagues. I lost teachers, professors who had taught me. I lost students who I had taught. I lost family members. I lost my father-in-law to COVID. In the mortuary, we saw every race. And before COVID, some races had their own mortuaries on religious grounds. COVID was the great equalizer. Everybody with COVID came to one place. Whether you were Christian, Muslim, Hindu, Jewish, we all had to follow the same for the very first time.
As little knowledge was known to the disease, though this may be, I can say it serves as a good advantage to most of the port health officers, having no option but to face the reality as it is on the ground. It also fosters us, or it pushes us to get more information about the disease, because we're also afraid of getting the infection, as well as looking back at our families, because you know that once you contract it at the end of the day, everyone else will lose confidence. Because if you are dedicated to fight a disease, or even if you are in the army and then you are soldier, everyone is looking at you, So if they see you being defeated and then they try to say, I think we're not going anywhere. I think it was courageous enough that people who were in the forefront, they got an opportunity to learn more so that they can prevent themselves indirectly or directly. They were also preventing the nation from getting the infection.
The COVID experience really brought about new skills in terms of addressing pandemics. I'd never thought that we could change the way we do business, but COVID taught us that anything can change anytime and we need to be more prepared than ever.
Well, for me, the most important lesson that I learned, and also learned it with disappointment, is that while we have all the evidence, technical knowledge and expertise, misinformation can actually destroy all that. So that for me really means there's a lot of work to be done, especially in public health or in the health sector, to remove myths, to remove a lot of beliefs and how they react to certain issues, especially concerning life and health, given that evidence might be there, correct information and everything, but can be overpowered by people's beliefs.
Personally, I said, this is my job. If I was in the struggle, it was not a question that, the sun is set. If you had to go and fight the enemy, you had to fight. Whether you fight the enemy midnight or you fight him at the dawn, you make a dawn attack, you have to do it. So, commitment, hard work, and perseverance.
Over 12.6 million vaccine doses had been administered across the country, and approximately 58.3% of the population eligible for vaccination had received the first dose, compared to 23% for low-income countries, as noted in a report published by Our World in Data on 31 October 2022. By the end of October 2022, Zimbabwe was recording fewer and fewer new COVID-19 cases and deaths each week. The COVID-19 epidemic curve had remained flat for almost a year since the last main pandemic wave. The national response was therefore on track. The pandemic was being brought under control and life was getting back to a new normal.
When there's a pandemic, maybe first of all, assume you are on your own. Assume you're on your own. Rely on your own capacity. Upscale your own capacity quickly. We didn't know that we had factories in universities and in our high schools to make masks and sanitizer. But there it was, that latent capacity became available and we were able to make use of it very quickly and effectively. So all of that are lessons learned for future response to other pandemics going forward. And God forbid we don't get another scare and another surprise going forward.
The world has now largely emerged from the COVID-19 pandemic. A sense of normalcy has been restored. 2 years on since the onset of the pandemic, our fears and anxieties have subsided. What we have learned as a nation is that by working together, we can achieve anything we set out to do. The government of Zimbabwe, in partnership with others, showed the highest level of commitment to the pandemic response. This commitment, delivered from the highest level and inclusive of all sectors of government and society, resulted in a robust, well-coordinated, and effective response that saved lives across our nation. And though we encountered setbacks along the way, ultimately, crisis response was strengthened. Valuable lessons were learned, and under the government of Zimbabwe's steady leadership, the nation has emerged today better prepared to handle the next emergency. This is the story that we will tell generations to come of how we as a nation came together to fight and overcome COVID-19, one of the biggest health crises that history has ever seen. May we continue to forge forward as one nation, united, better prepared, and ready to face challenges that may lie ahead.